Good morning and welcome to our final HIV Prevention and Education Virtual Summit presentation entitled The Ins and Outs of Understanding Your Labs. Before we begin, I'd like to go over a few reminders. Viewers, please make sure your mics are muted. The chat box is enabled for this presentation and can be used for interaction. You can ask questions using the Q&A box located at the bottom of your screen. Remember, this presentation is being recorded. Q&A will take place at the end of the presentation. At this time, I will turn it over to our panelists so we can begin the presentation. Thank you.
Hello, everyone. My name is Keith Carter, and I am part of the Elder Initiative and also part of the Penn CFAR. And today we're going to bring you Understanding Your Labs with Dr. Bill Short. But before we go on, the chat, like we stated earlier, the chat feature will be on. Dr. Short or Bill will be presenting in sections. At the end of each of those sections, we'll go and answer any and all questions that we possibly can. But please remember that don't make the questions personal. If you have some really detailed questions, you might want to go to your provider and seek the answers to those questions. And with that, I'd like to say hello to Dr. Bill Short or Bill. And here we go. Enjoy the webinar, folks.
Great, thanks, Keith. And hopefully you'll stay right where you are. Let me just pull up my slide deck. So while I'm getting this ready, this is really a repeat performance, although I lost everybody now. Just give me 1 second. It worked during rehearsal, and why it's not working now. Let's try this. There we go. Yeah, there we go. Let me just get it in slide presentation. So we did this performance, how long ago, Keith? I can't remember. It's been a while.
About a month or so ago.
Yeah, seems like it's longer, right?
Right.
And we really had a large number of participants, which was really exciting, join us. And so when asked to do it again, I was really happy to do that. So just a brief thing about me. My name is Bill Short, pronouns he, him, his. I am an infectious disease provider. I work at the University of Pennsylvania and really have spent my whole adult life caring for individuals living with HIV, and not only through clinical care, but also with research. So I love what I do, and I'm happy to share my understanding with you as well. And so just a little bit of background, and I have this image here for a reason. Most of us, including myself, we all go to see a provider. And one of the things that's very common at that visit, no matter what it is, whether it's a gynecologic visit, a specialty visit, a primary care visit, you name it, we always have to get labs. I swear that's something we always say, what do they do with all this blood? It's a very common question. And one thing I've noticed even for myself is when I go to see providers, I very often am given lab slips and told to go to the labs. I'm fortunate enough that I can look at the lab slips to see what they're for. Very rarely am I told what am I going for, or what are they looking for when they're sending me for all these different studies. And also within my own practice, I have patients who say to me, I just want to make sure you're checking me for diabetes. And then I realize I'm not doing a good job of explaining, every time you get a lab done, I am checking you for diabetes, liver, making sure your liver's okay, making sure your cholesterol's okay. So this presentation really is about, one, making sure you are all aware of what labs are being done or should be done, and really empowering you to go back to your provider and say, can we talk about my sugar? What has it been? Not just your labs are good, but you want to know what does good mean? And so hopefully by the end of this presentation, you will be able to have that understanding and be able to have a full conversation. Many of you probably already have a very good understanding, but hopefully we could take it to the next level. Here's what I want to talk about, and I think Keith kind of mentioned this. I'm going to talk about Cd4 and viral load, and I feel there's always something to talk about with those, right? We've been doing this forever. If you're living with HIV, you get Cd4 and viral load, no matter when you go get labs done. But I felt there's a couple things just to clarify with that. I'll stop, and what Keith said is I'm going to stop after each section. So I'm going to lump Cd4 and viral load together, take questions. blood sugar, take questions, kidney function, liver, each one of them I'm going to stop for. And then I put STI testing at the end because even in our little small group, that got the most attention. And everyone that was asleep, all of a sudden became wide awake and wanted to talk about sex like everyone does. And it's a fun conversation. The one thing I did not include in here, because it's part of care, I'll make a quick word about. So Pap Smears, and now Pap Smears, we used to talk about Pap Smear and everyone would think this is something we use for anyone who has a cervix or a vagina. And now we're going to talk about different types of Pap Smears. So in general, when you think of Pap Smears, you think of Pap Smears as a screening. A lot of people say Pap Smears are meant for, looking for STIs. You're right, but it's also a cancer prevention tool. And I want you to think of it that way, right? So when someone who has a cervix is having a Pap Smear, they get into the stirrups, they have a speculum inserted, and they're looking and they're taking a sample. That is really looking for precancerous cells and cancer cells. And hopefully you catch it early where it's precancerous and you can actually prevent cancer. So that has been around forever, and it's routine part of care. I will just quickly mention, anal Pap Smears, and this may be new for a lot of individuals. And, this has been listed in some guidelines. It's not quite yet a set of guidelines that tells you exactly what to do, but promise me, if I was doing this presentation next year, and if you like me, I may come back or you'll invite me back. That's going to be a big part of the discussion. And that may actually be the talk, because there was just a very large study that shows that doing this screening, anal cancer screening, and actually, if you find a lesion similar to like you find with cervical cancer screening, can actually prevent anal cancer. So that is going to be a huge part. You're going to see that explode over the next year. So just a quick word on that. All right.
And from my own personal experience on that, yeah, you really don't want to go through anal cancer, because I just went through 6 weeks of radiation and chemo, and it is not fun. So, yeah, just heed that warning I just gave you, or that word of advice.
Yeah, and now like I say, now we do have data. I'm going to, all right. Hey, Robert, how are you? Sorry, I'm going to call people out if I know you. I am absolutely going to explain what the percentages are. Absolutely. So they're coming. Hang tight. All right. So let's dive into this. There we go. All right. So let's talk about CD4 counts. So I've heard, CD4 counts, some people call them my counts, my T cells. What I usually say, CD4 count is a marker of your immune system. Remember, your immune system is there to protect you. A lot of people think of the immune system as only to protect you against infections. Your immune system also, remember, protects you against cancers. So CD4 counts are really important for us for a lot of reasons. It is a very dynamic number. And what do I mean by that? If you just look here at the normal range, right? So normally when we have ranges, so as providers, we go and we look and we say, hey, what's a normal blood count? And let's just say it's 8 to 10. It's a narrow sort of range. Look at this range. I mean, this is all over the place, right? So that's what I mean by it's dynamic. It changes all the time, and it causes lots of confusion. I would say out of all the labs I do, CD4 count causes the most confusion for everyone because it's all over the place. It has a diurnal variation, which means it changes at different times of the day. So you may get it early in the morning when you wake up, it's very high. The end of the day, it may go low. So it's all over. If you're totally stressed out, it may be lower. So it's really a dynamic number. What we're looking for is significant as a change of 30%. So, if you see your CD4 count today is 500, and then you go get a repeat done in 3 months and it's 450, that's not really a significant change. You're looking for 150 cell drop to be considered significant, because again, it's really changes. You're catching it at one moment in time. So I want you to think of that, and your providers have probably told you that. No, don't worry about that, and that's why they say that. So what do I do when I see a CD4 count? So it's very few things, and I listed this there, and I say that because, yes, I think I'm going to talk about the next slide. When you first acquire HIV and you get a diagnosis and you go in and you get labs, one of the first things we do is we say, let me check your CD4 count. And what is that for? When I say stage, you just want to know where someone is at. So if you come in and you have a new diagnosis today and I check your CD4 count and your CD4 count is 800, that means you probably recently acquired HIV. But if you come in and your CD4 counts 100, it may have been a while. And that sort of helps me say, you know what, you're at risk for certain opportunistic infections like pneumonia or, you know, thrush or things like that. And then I can actually give you antibiotics to prevent that while you're getting HIV medications to boost your immune system. So that's really what we use it for. Once you're on medication and stable, right? So you're doing well, you get your, you know, your viral load suppressed, it's been suppressed for years. I want to see if anyone in the audience, you could type it in the chat or the question and answer. What do we use your CD4 count for? So think about that. So if you are on antiretrovirals, you're taking your Biktarvy, your whatever you're taking, your Cabenuva, and your viral load is suppressed, what do we use your CD4 count for? We mainly use your viral load, but if you can tell me one reason, if your CD4 count's above 300, 400, I want you to think, oh, somebody typed the chat, perfect. It's like being in a room. All right, so after baseline though, so this is 2 years later, right? No one can think of any because we really don't do anything. And as a result of that, and I promise Robert, I'm coming back in a second to all those crazy numbers at the bottom. As a result of that, not really knowing, the guidelines have changed a little bit. Having said that, most of us still do monitor it every time you come into the office. But when you look at the recommendations for monitoring your CD4, it's when you enter care, obviously for the reason we talked about, but generally we don't use it for anything else other than making sure you're on the right prophylaxis. So if anyone's ever had a CD4 count that's dropped below 200, you've taken Bactrim, or I'll use the generic strain, trimethoprim sulfamethoxazole. You remember, everyone remembers taking Bactrim at some point. That's because your counts were low. But once you're out of that low window, we very rarely do anything with it. And so here are the recommendations, and I'll quickly say them and move on because again, this is very variable in terms of who does it. If your counts, if you're on antiretrovirals for more than 2 years and you have your virus suppressed, if your counts are 300 to 500, they recommend you check your CD4 count once a year. And if you're more than 500, you don't even need to check a CD4 count. I know that's really shocking for a lot of people. And I've tried it a few times, and I've had my patients call me say, you left out my CD4 count. And I try to explain, and they want to know their T cells. So, you know, it's something we've all gotten used to, and we don't want to break away from. But I just encourage you to think about why would you need that number? Does it change anything you do if you meet these criteria? And then there's reasons why we would do more, right? So if your viral load went up, we'd want to check to make sure your CD4 didn't drop. If you have new symptoms, you know, developing or initiating therapy that may lead to a reduction in CD4 count. And so then comes what we shouldn't be doing. And so a lot of times if you see your panels, I think just like Robert said, you get all these different numbers, right? They're called lymphocyte subsets. And if you go back here, this is from, you know, right from Epic. And if you look in here, it's just a bunch of mess, a bunch of numbers, a bunch of percentage, and all that does is causes you confusion. So you open up your portal and you're all excited because you're going to do what's right. You want to look and get your labs and look at them. And then you see this mess of numbers and you're like, yeah, what does that mean? I don't know what any of that means. So really what you're looking at is true numbers. So you're always looking for CD4. CD4 is the target where HIV binds. So these are your helper cells, right? And you're looking for the absolute count, ABS, and then you're looking at the percentage. So the question was, why both? So when this is done, it has to do the way the lab is done. They actually measure the percentage, that's the most accurate number, and then they calculate this number. So that's why the both of them go together. But all these other numbers, CD3, CD8 suppressors, and we we almost never do anything with them. I can't think of anything we would do. There was one research study that just showed that having a low CD4, CD8 ratio, CD8 is your suppressor cells, that having that ratio being low puts you at risk for malignancy. But other than that, clinically, like I would not look at that. If you were in front of me, I would see your CD4 counts low. I'd make sure, I'm checking you and preventing heart disease and kidney disease. I would do all that stuff, but we very rarely use that. So it's really just these two, the CD4 and then the percentage.
Bill, I have a quick question. Let's say
Yep, sure.
someone gets resistance.
Yep.
Would you still then go back and check their CD4 count?
So that goes right under here. So let's just say you have someone who all of a sudden their virus is undetectable, bang, 3,000. And you think they may be resistant. Of course, you want to make sure that their viral load didn't drop down. Absolutely would get it there for sure. Perfect question. All right, I'll do viral loads and then we'll stop and open it up for anyone who has questions. So HIV viral loads, again, probably the most important measure now from what I just, we're talking about is the amount of virus that's present in the blood. And I will say this is important, it's blood only, right? So we're not talking about genital tract, we're not talking about anywhere else in the body, the brain, it's really amount in the blood you're measuring. It's measured by a technique called PCR. So why do I bring that up? Do you really need to know what a polymerase chain reaction is? No, but when you look on your app sometimes, it'll say HIV RNA PCR. That's just a fancy word for the viral load. That's why I put that in there, right? Not because I want you to know what technique they use, but every lab is different. And so you want to know when you're looking, and I've had patients come in to me and say, I can't find my viral load. And then I show them, I'm like, this is it. And it's HIV RNA PCR. And then they're like, oh, I did not know that. So that's why I put that in there. The virus has a limited detection. So like the CD4 count, it's very wide. The lower limit is less than 20, which we call undetectable, but also can go as high as 10 million, right? So you can really catch a lot of virus in here. It is the most important measure. And what I want you to think about is everyone knows that having a viral load under 20 is undetectable, but the true definition of undetectable is less than 200 copies, right? So a lot of studies we're using now will say, if your viral load is less than 200, you're considered undetectable. Where does this come up in clinical practice? So if I had someone who's less than 20, less than 20, less than 20, less than 20, they come in, their viral load's now 75. It's the most common question I get asked. Oh my God. The two questions I get asked are, does my regimen need to be changed? And a bigger question is, am I going to transmit? I'm worried. I've always been taught U equals U, undetectable is untransmittable, but now my viral load's 75. What do I do? And everyone panics. So a couple things. One, you are at 75, you're still considered undetectable. And most important though, is you will not transmit. That the studies that were looked at for transmission and U equals U were under 200. So that's really important. And that's probably, I get more of a question about that than it does my regimen need to be changed, especially now. Everyone's really worried about that. So the definition in those studies for U equals U were under 200. And a blip is where you're somewhere between 50 and 200, and you don't run the risk of virologic failure. So if you were less than 20, less than 20, less than 20, you have a 75 and you're back to less than 20, that's what we call a blip, and it's nothing to worry about. All right, so I am going to stop and take questions. Now I'm actually looking.
So I don't see anything in the chat so far or the Q&A. So this is your chance. Do you have any other questions regarding like CD4, viral load for Bill? If not, we're going to keep the bus moving and we're going to move on to his next section.
You know what they're waiting for, that last section.
Oh, I know. Yes.
All right. I think I only, yeah. So blood sugar is, blood sugar. So when you think of blood sugar, a lot of people think, I want to be screened for diabetes. So your blood sugar is what we also call glucose. So if you look on your lab panel, you'll see it'll say, glucose. And that's really what your blood sugar is. Glucose is something the body uses for energy. A high blood sugar could signal diabetes. So what are the risk factors for diabetes? And if you look here, a lot of us have a couple of these. So being 40 or older, having an inactive lifestyle, during COVID especially, a lot of us sat at computers and did not do much. High blood pressure, Developing diabetes when you're pregnant, this is where your body is working hard to keep the glucose at a normal range. It's called impaired glucose tolerance. You have abnormal lipids, which we'll talk about in a second. That's cholesterol, things like that. Your body mass index above 23. And then if you have a family history of diabetes. So these are reasons. And then we could throw in there, things related to HIV. So, obviously this is something I'm concerned about, and I make sure every patient I take care of is screened for this.
So, Dr. Short, very quickly, where would one go for a BMI test, a body mass index?
So your BMI is actually done depending on what clinic you go to. So if you go in the clinic, as long as they do your height and your weight, they can calculate your BMI. So for me, when someone comes in and they get weighed by the medical assistant, and I go in my EMR and I type .vital signs to pull up my vital signs, the BMI is already calculated for me. And if you wanted to do it, if you knew your height and your weight, you could pull up, right? I'm actually going to do it as we speak, just so I don't kick myself.
And you can also do water displacement if you have the money for that, correct?
Yep. Yeah, but if you just type in your calculator, BMI calculator, yep, it comes right up. Calculate your BMI, and then you just put in your height and weight, and it'll give you your BMI. Yep, and it tells you what's underweight, normal weight, overweight, and obesity. So it's all in there.
And so I have one more question for you.
Yep.
You just mentioned about glucose.
Yep.
So what's the difference between glucose and the A1c? You
took my next slide right away from me.
Oh.
You took my next slide right away from me.
I'm sorry.
No, it's perfect. It's like you're there to help me along. So having said that, glucose is, there's a lot of different ways to think about glucose. So if I give someone a paper and say, here, I want you to go to the lab and get a glucose, right? But I tell them, don't worry about if you're fasting or not. That's what we call a non-fasting blood sugar. It's called random. If I tell them not to eat or drink for 8 hours, that's a fasting blood sugar. Really, that's what we want. Glucose tolerance tests, and if anyone's been pregnant, you know what a glucose tolerance test is. They give you something kind of like my Pepsi right here, full of sugar, but a ton of sugar in it. You drink it, and then they measure your sugar over certain time periods. Typically, it's a 1 hour, and then if that's wrong, you do it. If that fails, you do a 3 hour. That just measures your body's ability to handle a big sugar load or a glucose load. And then the last one is A1c. So A1c is a marker of glucose over 3 months. So let's think about this. If I'm going to go see my provider, and I can share my story. So my A1c is creeping up, and it's knocking on diabetes door ever so gently, right? So I know I'm going to go see my provider, and I was actually supposed to see my provider Friday, but I know I hadn't done what I had to do, so I canceled my appointment and rescheduled it. But let's just say, I know I'm bad too. I'm bad. I'm not perfect. But let's just say I had to go in there, and he wanted to check my sugar. So I said, I know I'm going to go see my provider. I am not going to drink these Pepsis all day, and I'm going to go in there, checks my sugar, and he says, wow, Bill, your sugar's 75. That's great. I walk out, and then I guzzle down a Pepsi, right? So that's only giving me a look at one moment in time. I cannot hide from an A1c. This A1c measures your sugar control over 3 months. So that's why you don't get that done every time you go, right? It's something that's done every 3 months. So if I go in January, that's going to reflect the 3 months before. Then if I go in April, it's the 3 months before. So this is a 3 month span. So I can cheat on these two right here. I cannot cheat in the A1c. So that's why most people are using A1cs. Does that answer your question, Keith?
Yeah, because my A1c was 9.5.
And that's actually in the normal range. And I'll show you. So here's what diabetes is. So when you say, how do I know if I have diabetes? So it is a fasting blood sugar, 126 or higher, on 2 separate occasions. So you have to have 2 separate tests to say that. Fasting sugar of 100 to 125 is what we consider pre-diabetes. And I'm going to talk about this for a second. or you could have an A1C of greater than 6.5. So I told you I was 6.3. So I'm knocking on the door. So I'm almost there. So that's pre-diabetic as well. So really what you want to do is if you go in and you have your fasting sugar and it's, let's just say 70, you're in a good spot. But if you go in and it's 103, 104, 105, that means you're pre-diabetic. And really what you should do if you are pre-diabetic, the best thing you can do is try to eliminate refined sugar, like something you would find in a Pepsi. And again, I'm using myself as a very bad example. Exercise, drop 5 to 7% of your weight. Those things absolutely can help. And I will tell you, as someone who is pre-diabetic, I went and got what they call a CGM, continuous glucose monitor, and I put it on my arm. And I watched my sugar with what I ate, and it was completely eye-opening to me. And what I found even more compelling was that when I decided to exercise, I watched that sugar drop down and stay down for a couple hours. So, you know, people tell you exercise is so important. And when you exercise, you have an effect that lasts well after you finish the exercise. That meter truly showed me that that happened. And it was so impressive that anyone that came to my house and was willing to be entertained by my sugar, I would actually show them. I would pull out my step aerobic, put on a video, do step aerobics for 5 minutes and show them how the meter just dropped down with the sugar and it stayed that way for a prolonged period of time. It is really impressive. So again, the goal is to make sure you take someone who's pre-diabetic and prevent them from diabetes, because we know diabetes leads to all types of complications.
So, Bill,
and it's a risk factor for heart disease.
So what would be a low blood sugar level, and what would be considered like, I was at 4, when I went to the hospital, I was over 400.
Right.
So
400, again, you're above 126. And if you're above 200, by definition, that's diabetes. That definitely, by definition, over 200. Now, again, there's lots of things you have to look at. You know, again, these are all individual things. You know, were you being treated with steroids at the time? What was going on at the time? Is this something that had been building up? So there's lots of different things there. You know, were you truly diabetic and not being treated? So there are lots and lots of things that you have to answer. So if I saw someone who came to me with a blood sugar of 400, I would, first of all, hydrate them, because, you know, sugar pulls water out and it really dehydrates you. So one of the things you want to do is you want to hydrate the patient, whether it's in the hospital through an IV or drinking plenty of water. Obviously getting some type of treatment. And I don't know if that's what happened.
So just a real quick question just around this diabetes and pre-diabetes. Can you ever lower your A1? We have a question from an anonymous person.
Yep.
Question. Can you get your A1C down to a point where you're no longer considered diabetic?
So once you're classified and diagnosed with diabetes, what you could do, and let's just say remember we said 6.5 is considered diabetic, right? So let's just say you decide, let's say you're 7.3. You're, by definition, you're diabetic. And maybe you don't want to go on medication. Maybe you said, I want to exercise, I want to lose weight, I want to do this, I want to do all these other things. I want to stop eating sugar, drinking, eating sugar. And you get your A1C down to, let's just say, 5.9 or 6. I wouldn't say you're not diabetic. I would say you were diet-controlled diabetes. That's how I would call you. But having said that, I've seen some people where they lose, 30, 40 pounds, or let's just say you are, I think I don't want to encourage that everyone should have gastric bypass, but I've seen people who have gastric bypass and they lose 100 pounds. And all of a sudden their A1Cs go all the way down. They're able to stop their metformin, maybe their, injectable, whatever it is they are. I would still say they're diabetic, but they're off all medications, right? Because you always want to keep looking, because you don't know what could trigger that, right? Something had triggered that before. Your body became resistant to insulin. I would just call you completely controlled. but yeah, you absolutely can come off all this stuff. Yeah, absolutely. And I've seen people do it. When people are really determined, they drop the weight, they fix the diet, and they really can come off all this different medication. Absolutely.
So to our anonymous attendee who asked that question, I hope that answered your question. If not, feel free to put another question or in the chat, and we'll address that for you. Thank you.
Yeah. So I would also say, just remember that diabetes is a strong risk factor for lots of things, including heart disease. And so having diabetes, again, you want to, so that A1c helps in making a diagnosis, but it also helps in looking at long-term complications of diabetes, right? You don't want to leave your A1c 8, 9, 10. You want to make sure it's on the lower end, so under 7, preferably around 6.5-ish, because again, you're going to then run the risk of all these different complications, kidney disease, eye damage. So it's very, very, very important. All right, let's talk about kidney. So there's only one slide on kidney. I'll do this and stop. So kidneys are extremely important. Right? We have two. Kidneys do a lot of things. They actually help do a lot of filtering of the body through the body. They get rid of lots of waste. There are a couple different things I look at when I'm looking for kidney, and I just listed a couple here. So one is I measure, serum creatinine, and you'll see that listed in your lab slip. It's usually in something called a basic metabolic panel or a comprehensive metabolic panel, or but you could just get it alone. So creatinine is a waste product and really is one of the most direct signs of kidney function. The problem with creatinine alone, so I don't use it alone, and the reason is a lot of the drugs we use for HIV mess around with different receptors in your kidney. And so your creatinine can go up or down, and it really has nothing to do with your kidney function. So that's why, again, it's important to do a lot of different tests. When I do a urinalysis, I always, say, can you give me a urinalysis? What I'm looking for in there is a lot of different things. I'm looking for protein. Remember, your kidneys are, when you look under the microscope at the kidney, you shouldn't be losing things from your kidney except what comes out to the urine. But if there's damage in the kidney, there's all these different tubules, you start leaking things. So protein, sugar, and then white blood cells. If I look in the urine and there's a lot of white blood cells, you may have an infection, you may have something else going on. So urinalysis is important. And then what we do is we calculate something called the eGFR, the estimated glomerular filtration rate. This just tells how well your kidney's working. Some medications, again, need to be adjusted based on this. So example, Truvada, right? You use Truvada. If this number goes below 50, we have to cut that back to every other day, right? So this is a marker of your kidney function. So when I'm looking at, when someone's coming into me, and let's just say that, every couple months I'm going to monitor their kidney function, this is sort of the minimum that I would use to look for. I want to make sure, one, the kidney function is good. And then I calculate this by using this and some other different factors. But are your kidneys working well? And then I want to make sure all the tubes in there are working well. I don't see a bunch of urine in there. I don't see a bunch of sugar in there, because I could also diagnose diabetes through this way. If you're full of sugar in there as well, you may be diabetic. I will say, not only does HIV impact the kidney, diabetes impacts the kidneys and everything else you can imagine. So if you're diabetic and have, abnormal kidney function, you run the risk of going on dialysis. So that's why all these numbers are important. So when you're asking your provider, have you looked at my kidney function, and they say it's fine, ask, what do you mean by fine? Is it, if you're not given a urinalysis, one thing I've learned to do, because a lot of patients I would give urinalysis to, they were like, I can't urinate. And I realized that, I wasn't telling them why I was doing the urinalysis. And I make it very clear, I'm not doing a drug screen, right? Because we know providers do that, right? Providers will order a drug screen and not tell you that. So I tell them, I am looking at, there's no drug screen. I am looking at your kidney function. I'm looking to see if you're spilling protein or you're spilling sugar, which can help me in other things. Because if you're spilling a lot of protein, That's really bad in many, many ways. So, blood work as well as urine is really important to look at your overall kidney function. Because again, you don't, along the way, there's a spectrum of kidney disease. You want to catch it early on. You don't want to wait to the end where it's time for transplant, right? There's lots of things that happen as your kidney function is declining over time. So you want to sort of catch it early on. Maybe it's something you can fix. Maybe you need to go see a kidney doctor early on. You don't wait till there's that spectrum. You don't want to wait till the end and say, oh, now you got to go see a kidney doctor. You want to do that somewhere early on, because again, maybe you can get listed for transplant before you have to go into dialysis. Questions on the kidney?
Yes, Bill, I just noticed that you mentioned something. You said if you get you're doing your kidney stuff, if you go below 50 on that, and you said you would take your dose of Truvada and do it every other day. Does that mean, could you explain that a little more?
Yep. So there are certain drugs that are cleared by the kidney. And there's lots of drugs that are cleared by the kidney. So for HIV, the ones that are cleared by the kidney are what we call the nucleoside reverse transcriptase inhibitor. So that's your Truvada, your Descovy's, your AZT, your DDI, your 3TC, all that whole class. The one that is not cleared by the kidney is Abacavir or Xiagen. All the other ones are cleared by the kidney and they need to be changed. So in other words, if my kidney's functioning, and the GFR comes at a number. So let's just say it's 100. So everybody's, what we consider 100 around normal. If you're working at 100, there's no reason to change your medication. But if your kidney function over time is declining, and now you're down to, let's just say 45. And you could see this on your labs. So if you have access to your labs, you'll see this number. If you're down to 45, that means that some of those medications need to be what we call adjusted. So Truvada, for example, Truvada is once a day, but if you get below 50 in that eGFR, you then have to go to every other day dosing. That's what that means. And let's just say you went on to dialysis. You can't take Truvada once a day. You would have to break it up, the components, and then you would take one drug, like 1/6 of the dose daily, and then Viriad you would take once a week. So you have to break it up like that. So that's where that comes into play. So that's why these numbers are really important. Hopefully I didn't confuse anybody with that.
Does anybody really use the nukes anymore, like DDI, D4T,
No.
the D drug? No, I didn't think so.
I hope they don't. I hope they don't. No, really what's used is 3TC, FTC, or lamivudine, emtricitabine, tenofovir, the two types that are in Descovy, and Truvada. That's really what's done. And then we use AZT during pregnancy, largely through the IV.
So could someone go from Truvada to Descovy then?
Yep, so Descovy, what will happen there is this number, the eGFR, you can use it till it gets to less than 30. So it's even lower. You don't have to do anything. Yep. And your pharmacist provider, they should all be following this when you're in the clinic. And most people know that you have to adjust these medications. It's really important.
So I noticed that we don't have any questions in the chat thus far, so we can keep moving to liver function.
All right, I just want to double check. Yeah, we're almost off. All right, so for liver function tests, and this is a little bit of a misnomer, the terminology. So we lump things together as liver function tests, but really they're not. These are liver injury tests, and they're different types of tests we talk about. So when you look on a liver panel, you see AST, ALT, there's other names for them. We see bilirubin and we see alkaline phosphatase. Each one of these things mean different things. So I'm going to start with the most common ones. So AST and ALT, these are enzymes. And what happens is when they are elevated, they can signal damage. So the number one question is, what type of damage? It can mean anything you think of. Typically when people hear liver and I say your liver tests are up, the first thing they say is, I don't drink. And that's true. Alcohol causes a lot of these changes, but there's a lot of other things other than alcohol that cause these things to rise. And I'm going to go through a few in a second. Medication can do it, other drugs, and I'm not talking about what I'm talking about ones that are prescribed. So, certain drug classes all can have an impact on this. So when I'm looking at these numbers, I want to make sure they're in the normal range. One of the things that has happened recently, and this is your liver here, I will say, if you go back here, you can live without kidneys. You have to go on dialysis for sure. You cannot live without a liver. Your liver does everything for you. Your liver is one of the most important things in your body and one of the most important organs in your body. And there's many things you can do to preserve that, right? And that's why monitoring liver tests are so important, because we can't see inside the body. We're not sticking a needle in there and doing biopsies all the time. So we have these markers that are sort of indirect measures of your liver function. So they're important for us. And we need to take them serious when they're elevated. So one thing that we're seeing very common now in the field is liver tests. And let's just say your top normal is at 40. We're seeing 50, 60. So when I see that for someone, I am making sure they don't have any hepatitis. I check all the blood tests for hepatitis, which we didn't talk about here, but I figured I could lump it in my discussion. So I checked them to make sure hepatitis A, hepatitis B, hepatitis C. That should be done when you're first diagnosed, and periodically throughout, depending on a lot of different things. If all those things are negative, the person tells me they're not drinking, they're not on different medications that could interact, I go ahead and order an ultrasound, which actually looks at the liver itself. And what we're seeing now, a lot more than we ever saw before, is what we call fatty liver, where there's a lot of fat deposition in the liver, and they're causing these mild elevations in your liver enzymes. And while, again, fatty liver used to be thought of in the past as being benign, we now know that over time, this can, I'll now answer the question. I'll go back to kidney in a second. Over time, fat in the liver can actually lead to scarring and cirrhosis. So it has to be taken serious. And, we don't have much to treat it now, but what we do have to treat it is good old-fashioned diet, exercise, and weight loss.
So would you describe what cirrhosis really is to those who may not?
Yeah, of course. So remember, your liver does a lot of things. So what cirrhosis is basically scarring of your liver. And that scar is basically like if you get cut on your skin, right? So when you get cut in the skin, you form a scar, but that scar with time goes away. Maybe it's a little faint. In the liver, the scars stay, and they basically you lose function. It depends on how much scar you have, and it causes lots of damage over time. Your liver can't do its function. Your liver can't break down all the different things it needs to. It becomes very stiff, and you can't get the blood through it. So it's dangerous and can actually lead to death. And a lot of times people will need to actually have a transplant because, again, I told you, can live without kidneys. You cannot live without a liver. Liver is extremely important for you. And so these tests are really, really important and should not be ignored.
So before you move forward, we just had a quick question from Robert.
I want to go back to that, but I don't want to lose the momentum. I saw I just want to finish the liver because it's only one slide. He has a great question. I think that's going to bring up a lot of questions too. So I'm definitely going to go back to him. So the other two are bilirubin and alkaline phosphatase. So bilirubin is a fluid that produces when your red blood cells break down. I put this in here because everyone knows someone's jaundiced, and that's what bilirubin is. One of the drugs, actually two of the drugs, but we don't use them much anymore. So indinavir or Crixivan, which was, if you've been around, you know what indinavir is, and atazanavir or Rayataz can actually cause this number to go up and cause yellowing of the whites of your eyes. Doesn't mean your liver's damaged, and this used to cause lots and lots of confusion. It just does something with the receptors that help take up the bilirubin, and you wind up having more in your blood. And so it winds up, believe it or not, one of the first places it gets deposited is the white of your eyes. One of the first things people notice. And so it was sort of a, oh my God, do you notice your eyes are yellow? And that was because it can happen through some of the drugs. So if you've ever been on either of these and someone said your eyes are yellow, one of my not favorite stories, but I remember it so well. When I first got out of training, I had a newly diagnosed person who went on this, and I really tried to persuade him from not going on this. And he was like, no, I'm fine. And he worked at a place where it's very, I don't want to say where because I don't want to out anyone, and not that you may know him, but just in case, they would take it very serious because it was some type of health setting. And sure enough, he went in there and his eyes were glowing like a yellow highlighter. He was sent home to go get hepatitis tests. And so I had to switch him off of this drug and it went away. So, again, these are just, and we don't use these drugs much anymore. And it doesn't mean if you're on that, because a lot of people went on these drugs and it never happened. So it doesn't happen to everybody, but it does happen at times. And it also depends on the level of that bilirubin. And then alkaline phosphatase we use to indicate some of the tubules in your liver. So these are the things, again, collectively. So I think what you've noticed, at least with kidney and liver, is it's not just one specific test. It's really a whole series of tests. And this is just the beginning, because then if something goes wrong here, that takes me to do another set of tests, but I don't do them on everybody. So if I order my liver test back and I see AST, ALT, and I will tell you, bilirubin's broken up into total and indirect. And then there's alk-phos. Each one of them mean a different thing to me. So when I see the AST is up, that something's telling me, something's happening to the cells of the liver. When I see bilirubin up, I'm like, is there an obstruction somewhere? Same thing with alk-phos. And alk-phos is a little tricky because it's also seen in bone. So I have to then figure out, is this bone or is this liver? So it does get confusing, but I think the most common ones are these two up here, the AST and ALT. And so I just want to go back and then I'll take questions. So the question in the chat was,
I believe it was, he was on
Myriad.
Myriad, yes. And then the question is, because he had an elevated creatinine level, does that mean he can never go on any regimen that contains tenofovir again?
So Myriad was the older form of tenofovir. If for those who are unfamiliar, it's what's in Truvada. So the question is, what caused that kidney function to go up? Was it truly the Myriad, or was it something else combined with the Myriad? And again, remember, Myriad is a little stricter in terms of when we start changing the dose. Remember, that's somewhere around 50. But now, you can use things like Descovy, which is the newer form that are better, where you're not going to have as much in your blood system. Most of it's inside the cells. So no, it doesn't mean you should not go on any tenofovir containing regimen again. It just means you have to be monitoring it closely. And again, the newer form's better. And it just depends in 2007. So, the question is, with tenofovir, it used to be, and again, 2007 was very different than where we were now. We used a lot of boosted protease inhibitors. So when you were on a boosted protease inhibitor, either with ritonavir or cobicistat, that actually raises the Myriad levels. So it made it a little harder. So you had higher levels. So that's why Descovy is probably a better formulation for you to use. And again, it all depends, did you have damage to some part of your kidney? But the answer is no. It doesn't mean you should never go on it again. It's all based on the situation.
And don't forget, Robert, don't forget to talk to your provider about that as well, just so you get certain clarity from your provider as well. It's a great thing to have a discussion with him about that issue.
All right, I'm just going to stop for a minute because everybody's really quiet in the audience.
We had Robert said, thank you. Oh, you're quite welcome. Keep asking the questions. We love the questions.
Yes, please do.
And anybody who are in the audience and participating in this webinar, please feel free to type a question in the chat or the Q&A, because Bill loves questions and he likes an interactive session. So
I get tired of talking. I'm boring. All right, I'm going to keep going.
So our next section is going to be lipids.
Yes, or fat in the blood. There are 2 slides of it, and then we'll open it up. And I think after that comes sex talk. So lipids are fats in the blood, and these are complicated. So a lot of times you'll hear providers saying, "Good, I need you to get a fasting lipid panel." This is again where you want to come in and you're not eating for a certain amount of hours. Fats are needed. So there's a big misconception that all fats are bad. That is not true. Fats are a source of energy. They carry some vitamins, believe it or not. They help make hormones. All your cells have membranes that fats are really important in, and their fats are carried in this sort of protein mixed with things are called, lipoproteins. So fats are not always bad. It's just excess of fats. And, again, you see up here, milk, cheese, dairy, and eggs, that's typically what we think of when we think of fats. And I think more of a big filet mignon or some type of big fatty steak up there. But the other thing to know is that some antiretrovirals can raise lipids in your blood. This is a very complicated topic, and there's different mechanisms, and some are more coming off of one and your body responds. So just know that some can raise your lipids. Common question is, should you come off of that regimen? That is a conversation with your provider, because maybe you need to be on that regimen for a certain reason, right? It's some reason I can't just pull you off of that regimen and say, yes, I'm going to give you this other regimen. So that's really a conversation to have, but know that some antiretrovirals can raise your lipids. What does a lipid panel consist of? It consists of these 4 things. So when I order a lipid panel, I get these numbers. Just quickly, and I put it here in a cartoon, there's 2 different cholesterols that we talk about, the good and the bad. And it's almost like, and I failed to mention this in the beginning, we talk about Cd4 and viral load. And again, these are important because, when you, God forbid, if you then go to another healthcare setting, you go to the emergency room, you go see another provider. And I've had it where I ask someone, can you tell me about your counts, your Cd4 viral load? And they always say, oh, my T cells are undetectable. And I'm like, that means your T cells were really low. No, always high. So there's always this confusion of what's high, what's low. And the same thing with lipid panel, right? So we know with CD4, you want your CD4 cell high and your viral load low or undetectable. For here, the HDL cholesterol is good and the LDL cholesterol is bad, right? And this is what it looks like. Because the HDL cholesterol takes the cholesterol away, LDL brings it to. So again, if you think of it, this is high density lipoprotein. This is what a normal artery would look like. You notice everything is flowing through here, right? You have mostly good cholesterol, and here's the bad. It's carrying the cholesterol away. But look what happens when you have mainly LDL. Everything's narrow. So if you just look at this.
Can we open that up? Open that artery that's narrow. Can that be opened up?
Yep, it can. But it's not, again, it's not without complications, right? So going in there. So this is all a buildup. This is, in the wall. So is anyone in the audience? Let's see if anyone wants to type in, other than Robert. But Robert, you can definitely do it. What's the problem with this artery right here? Like what's the difference between the narrow artery? Why do we care about narrow arteries, right? The blood's getting through here. Why do we care? Does anyone know?
Stroke.
That's the big fundamental question, right? So stroke. Well, why stroke? Why does that happen? Right? Blood's flowing through. I love to trip people. I love to make people think.
I was going to wait.
Oh, hold on.
He has to work harder to pump the blood.
Yep, exactly. And not only that, think about this. If you were trying to swim through this, right? That's pretty straightforward, right? You go through. Try to swim through this. I think of people who go swimming in caves, which I would never do. I'm scared to death of that stuff. But you have to maneuver around things. Same thing here with the blood. This is not a straight through swim. So what happens is you have things that come through and start banging onto this and start getting stuck. And I don't know if you can see can you see my pointer okay?
Mhm.
All right, so the blood's flowing this way from left to right. Same thing here. And what happens is it starts banging right here, right? Because here it looks like it's coming through, okay, bang. It starts damaging this wall. When this wall is damaged, there's little things that stick out, little collagen, and all of a sudden things start developing on here. And look what's happening. I mean, I'm making it. You start building. What's happening to that hole as this is filling in? It's getting narrower and narrower until eventually it just closes off here. Then all this area below it, you don't get blood. What does blood bring to the area? Oxygen. And that's what a heart attack is, believe it or not. It's having that area obstructed. And, you know, if you're obstructed very high, you could lose a whole lot of muscle there or other things. I mean, this can happen in your legs. So this is why, you know, people have, you know, we think of cholesterol just in terms of the heart, but think of your legs too, right? If you're walking, you know, people walk and they say, oh my God, I got really bad pain in my calves. This can happen down there too, and you're not getting the oxygen, right? Blood's flowing for what? To get oxygen to the muscle to be able to contract and move. You keep contracting and moving, but you're not getting oxygen there. You're going to get cramps. You're going to get really bad pain. So that's what happens here. Now, Keith mentioned, and then let me just see something here. Oh, good, perfect. It was you, Keith, responding. You know, so what can you do here? So there's a couple things. You could take blood thinners to make the blood thin, and so it's not as thick flowing through, and so you don't have to worry about if this is, you know, damaged here, that things will stick on it. They won't stick. It'll maybe keep flowing through. But the other thing is, if you say you're having, because this is narrow and this is in your heart, you're walking up a flight of steps, you're getting crushing chest pain, and they go and they find out, oh, your artery is really narrowed. What can they do here? They can put a balloon in here. They can open this up. They can clean this all out, the plaque, but that's a fix. And I'm going to leave it at that. That is a fix. So I don't want you to think that that's great. They could put a stent in here. A stent's like a little mesh that opens everything up. These are all fixes. You really want to keep it like this, right? So that's why having good cholesterol, HDL, I always say, to me, I wear two hats. I wear my doctor hat, which is, you know, I try to prevent and treat, but then I also have trained in public health, and that's prevention. I want to prevent. This is preventing this from happening. Once I have this, I then want to prevent damage from that, but I really want people to be here. So this is why having a good cholesterol, that's why people talk about diet, exercise. It's really to get you here instead of getting here and then trying to fix it. And, you know, because you still have the problem. And you know what? Once you fix it, it can happen again and again.
Oh,
Right?
really?
You're just introducing effects. You're only fixing it. It's the same way with, I think of it as a broken pipe, right? So if I have a pipe that's broke and I don't get a whole new pipe, which obviously you can't get a whole new vessel unless you get a bypass. We'll talk about that. You know, I tape the pipe and I get it fixed. It's still broken, right? And I got to make sure I do everything I can to prevent that break from happening again, but it's still broken. And let's just say then I get, this is so narrow that I have to have a bypass. So a bypass is where, you know, they open up your chest and they take another artery from another place and they like put it here and they bypass this blockage down to here. Two things can happen. One, you still have this, but you're bypassing it. That bypass graft can absolutely get the same blockages in there. So again, these are all fixes. And that's why really the key is prevention right up here. You gotta go back to preventing it, right? Because you can do all the things in the world to fix it, but you really want to prevent it.
So Bill, we had a quick question again.
Yeah, of course.
Can you please explain the difference between blood pressure and cholesterol in the blood? Are those measuring the same thing?
Say blood pressure and
cholesterol in the blood, are they measuring the same thing?
No. So when you're measuring blood pressure, you're looking at, you know, what's the heart you're beating. There's two numbers. You get 120/80. systolic and then diastolic. What's the heart pumping at and what's the heart relaxing? That's totally different than cholesterol, but both of them are considered risk factors for heart disease. And you know, what does blood pressure do? Blood pressure that's normal is good. Blood pressure that's bad can damage this lining in here and start the same process. So, you know, having a stroke, the biggest risk factor for having a stroke is high blood pressure. These arteries going up to your brain right here, the carotids, they can get damaged by high blood pressure. That high pressure forcing against the wall can damage the wall. And that's, even if it looks like this, that same collagen can come out and start to form clots in it too. So not only do you need good blood pressure, you need good cholesterol as well.
So I have a quick question for you as well. So you said 120 over 80. What in the hell does that really mean? What's 120? I mean, what I mean, someone says, oh, you have high blood pressure. Well, how do I know that? I don't know what it means.
So again, those numbers are, there's two numbers. When someone takes a blood pressure, you're going to get two numbers. There's a top number and there's a bottom number. Very general way to think about it is the top number is your systolic blood pressure. That's the pressure when the heart's pumping. And the bottom number is the diastolic when it's relaxing. So you wanted somewhere around 130 over 85. That is good. You know, what I see a lot in the clinic is 190 over 100, 190 over 110. They are not good numbers. You do not want that. And you know, what that does is puts you at risk for lots and lots of things, including your kidneys. It can damage your kidneys. So having a good blood pressure is really important. And again, we could spend hours talking about it, but there are lots of reasons why your blood pressure could be up, right? Maybe it's something that's going to happen to you. Maybe you've gained a lot of weight. Maybe there's so many things that happen, but bottom line is you want to have, when you walk out of your provider's office, you should note what your blood pressure was. And again, a lot of times things are done automated for you. So I encourage you to say, if you don't know, could you tell me what my blood pressure was? And if you hear someone say, oh, you were 150 over 94, say, well, that's not normal. You know, are you worried about that? You know, put it back to the provider, right? Because they may just, you know, you come in, you have a certain amount of time and you have to talk about, how have you been since the last visit? Your antiretrovirals? Do you want a COVID vaccine? Do you need a booster? I want to screen you for diabetes. Let's talk about this. There's so many things to talk about. And you may not look at that vital sign, but that blood pressure is there and it's bad. So I encourage you to say, what is my blood pressure? And I see so much high blood pressure in my practice. And it's really scary how much high blood pressure I see. And that blood pressure needs to be controlled. You could just Google and see what are the effects of high blood pressure. There's tons. Heart disease, kidney disease, damage to the back of your eyes. I could go on and on and on. You have to have control. Boy, that's stimulated conversation. I see it's coming in now. All right, let's do it. If the person has stents placed and the cholesterol builds up, what would be a fix for a situation like that? Are the stents? So the stents can be replaced. But again, what I want you to think of, these are excellent questions. You're going into this little area that I'm showing you right here. This is not a big area at all. I mean, at all. These are very small areas. And the more you go in there, the more you run risk of things. So think of all this as cholesterol buildup. I'm going in there with a wire. I could flip this right off and cause damage. So you're right. There are things that can be done. Sometimes they say, you know what, I can't go in again. There's so much damage in there, or it's too narrow. Maybe we're just going to try to manage you with medication. So you're right. You can keep going in, but just remember, each time you go in, as this gets narrow, you're trying to blindly lead a wire through here to do all types of things. And as you're going through, you could knock this off. You know, I mean, there's so much that can be done there when you're doing that. So again, great question.
Let's keep those questions coming, please. You know?
Yeah, please. These are so important. Rather than hearing me talk about, I rather you hear the basic stuff and then, oh, here we go. Is that another one coming through? good, perfect.
So I think you have to just cover triglycerides real quickly.
Yep. So triglycerides are what I call the fats, the free fats. So if you eat a cheesesteak, if you go and eat a cheesesteak, and I'm picking on the bad thing, they're the things that are floating around in your blood, right? They're a form of fat. They're used again for energy as well, but they're separate. So I usually lump all these together, and then there's triglycerides. And again, these are different from cholesterol. They do different things as well. But like everything else, they have to be at a certain level, and you want to try to keep them under 150. So again, you want to say, I want to know my cholesterol, my good and my bad, and as well as my triglycerides. So they're all important for you, every one of them, for lots of reasons. And this is exactly what I talked about. The LDLs carry fat from the liver to the rest of the body, and then you build up. You don't want that. That's why you want to have a high HDL.
I have a quick question for you before we get into sex. What happens? What do they call it? Like you have visceral fat, like around some of your organs. Where does that fat come from?
So that's a whole other topic.
Okay.
But it's a whole other set of topics. So when I talked a little bit about fatty liver, it's the same thing. People are gaining weight. There's two types of weight you can gain. One is called SAT, S-A-T, and the other one is VAT, B-A-T. So I wish I could, there's no way to write. So SAT, S-A-T is what I call the spare tire. So if you grab your waist and you can grab a hunk of whatever, that's called subcutaneous adipose tissue. That we know is the beer belly, that we know is all the excess calories.
The love handles.
The love handles, exactly. I was just feeling my own. That is a little different. That is visceral adipose tissue, and that's worse. That's on the inside of your body, and that lines all the organs. So that's actually really bad. It can cause lots and lots of problems. And again, all these things can improve with diet and exercise. I know that sounds crazy, and I know it's hard, but they really can improve with diet and exercise.
Is there any medication currently to treat visceral fat or to reduce the amount of visceral fat?
There are. I will just leave it at that. There's
okay.
There's a lot. There's a lot coming. No. There's a lot coming down the line. Yes, and if you're diabetic, there's certain things you can do that actually can reverse the fat. Yeah, so there's a lot. There's an injectable for that type of fat. So yes, there are definitely some. They're not easy pills or injectables, but yes, there are treatments out there for sure.
So before we move on to the big thing that everybody wants to talk about, sex, any other questions for Bill on anything that we've covered thus far? Alrighty then, we are going to move on to the drip.
Yes, STI testing. So sexually transmitted infection testing. Some people call it STD. When I'm going to preface this by saying the reason I put this up here is, so if you call your provider and say, I would like to have STI testing, you want to ask what you're getting done, right? Because it's important. Some people say, I'm going to check a urine for this. I'm going to do this for this. I'm going to do this. You want to know what they're actually doing, right? Because unless you have symptoms, so if you're coming into me and you said, I have a rash on my palms and soles, well, guess what? I know exactly what that is, right? I know that.
Very simplest.
Yep. If I have a drip, if I have a penile discharge, a urethral discharge, a vaginal discharge, I'm probably thinking gonorrhea, chlamydia, trichomoniasis, other things. But if I'm just coming in and saying, I had a sexual encounter with someone, I'm a little worried, can you do testing? You want to make sure you're getting everything done. You really want to make sure that's important. And so what I typically say is ask for syphilis testing, gonorrhea, chlamydia, trichomonas, and then hepatitis C and B. And I'll just say one word about hepatitis B. And I didn't put it in here because I think if you have HIV, you should have been vaccinated against hepatitis B. This is preventable with a vaccine series. And, you know, and maybe you're someone that doesn't believe in vaccines, and that's fine, but there is a vaccine series out there for hepatitis A and B. There's not for C. So, but if you're not protected, and again, ask your provider, do I have protection against hepatitis B? You want to know that, you know, because again, there's so many things providers have to do. That's why I'm putting it on you. You need to go ask your provider, am I protected against hepatitis B? And if not, say, you know, can I start something to get me protected? That is something you never want to get. It is preventable. And the problem with hepatitis B, it can lead to liver cancer and all types of problems. And once you have it, there's nothing you can do. So you want to ask that. Before I go on, does anybody know, not you, Keith, anyone in the audience know what this thing is right here in the picture? Anybody want to type it?
Wait. Those are no.
I'll give everybody 30 more seconds, then I'm going to tell you.
I think I know what it is, but I'm not even sure about that one.
All right, that is syphilis.
Oh, it's a spirochete.
Yeah, it's a spirochete. That's exactly what it looks like. Yep, believe it or not. So these are the things you want to get tested for. Now, mind you, each one's different. So syphilis is done through a blood test. Gonorrhea and chlamydia, we're going to talk about in a second. Specimen and hepatitis C and B are done through blood testing. Here is an important thing. And now, mind you, the recommendations are largely for men who have sex with men. However, if you feel like this is something you should engage in or you engage in, then you should definitely ask. So STDs do occur in the throat and the rectum. Men who have sex with men are often at risk. The problem with this is there are often no symptoms. And how do you figure it out? You detect it by screening. If you do not have HIV, it does increase your risk of HIV acquisition. And when you screen men who have sex with men for gonorrhea and chlamydia, 1 in 8 had an STD in the throat or rectum, and 1 in 3 had not been screened in the last 12 months, which is really, really unfortunate. So really you should have, if you're a male who has sex with other men, you should at least have this done once a year. If you're having more frequent encounters, I do this sometimes every 3 months or 6 months in patients I take care of. So let's just say you come in and you say, I want to have screening for an STI, STD. Someone does the blood test and they just do a urine and they don't screen your throat and the rectum. They are missing a huge percentage of gonorrhea and chlamydia because again, it's often in the throat and the rectum and they have no symptoms. So it's really important you get that comprehensive, all 3. Now, I tend to do anyone that's had, encounters and wants it. I don't just limit it to men who have sex with men. And I'm finding gonorrhea and chlamydia. And these are really important to do. You really want to have this done. So I think the take-home points is when you're asking for STI testing, you want to make sure it's comprehensive testing. It's syphilis, it's gonorrhea, chlamydia, and all sites, trichomonas, hepatitis C, and know your hepatitis B status. And know your hepatitis B status before you engage in condomless sex, right? You want to know, should I get a vaccine out there that can prevent me from acquiring Hep B? Don't wait till it's too late. It's preventable. Go out and ask your provider. Everyone has hepatitis B vaccines available to them to protect. And again, if you got hepatitis C, I mean, nobody wants hepatitis C at all, right? Nobody wants Hep C, but I can give you medication and cure Hep C. I can't cure Hep B.
But remember, you can still, even though you may be virally cured for Hep C, can you in fact be exposed to Hep C again?
Oh yeah, you can get it. You can get infected again, but at least I can get rid of it. I cannot never get rid of Hep B. Never, never, never. So please, please, please engage these conversations with your provider and make sure you have hepatitis B protection through immunity.
And one more thing, could you explain to people, to our attendees and participants about the PCR? Like if you've been exposed to syphilis,
Yep.
whenever you get retested, it's always going to come up positive for syphilis. However, I'll let Bill answer the rest of that.
Yeah. So there's two parts of testing for syphilis. So let me cover three things with that. So first of all, if you have a sexual encounter with someone and they say to you, they call you 2 weeks later and say, listen, I just found out I have syphilis. So big misconception is I need to get tested. So you need to get tested for other things. You need to get treated for syphilis. So if this person you had a sexual encounter with, it was condomless, which is fine, you need to get treated. I had someone who, I mean, he challenged me, and I said, I don't know what to tell you, but if you're telling me your partner had syphilis and you had condomless sex, you need to be treated because you had exposure. If it's within 90 days of that exposure, you give the treatment. You don't test, it's you give the treatment. So if that person called you 2 weeks, a month later and said, oh my God, I'm sorry, we had a sexual encounter, I got diagnosed, you don't wait for testing. You go out and get the treatment for syphilis and you abort it. You don't have to worry about it. It's the best thing to do. Now, what if they call you and say, or you don't know anything, you never see the person, you and the person never talk again, and you're like, I just feel I need to be tested. That's different. And you go out and get syphilis testing. Syphilis testing comes two ways. There is a screen part, and then there's a confirmation part. The screen part is what is in the form of what we call a titer. So it's that number you see where it's 1 to 2, 1 to 4, 1 to 8, 1 to 16. And then there's an antibody. The antibody stays positive for the rest of your life. What changes is that titer. And that titer is how we tell if you're cured or not. So the titer is 1 to 256, right? 1 to 64, 1 to 128. We look at that titer, we give you treatment, we watch that come down by 4. That's how we know if you're cured or not. But just know the antibody will stay there for the rest of your life. I hope that makes sense for a lot of people. So there's two components of syphilis testing. One is the screening part, which is that titer number, and then there's an antibody. And just think of antibodies as something that stays for the rest of your life. So if you had, let's just say chickenpox. So I had chickenpox as a baby or as a 5-year-old. That antibody stays with me for the rest of my life. I don't have chickenpox now. I feel fine, but I have the antibody for the rest of my life. That's how someone knows when I started work at Penn, they want to know, did I have chickenpox? They check my antibodies. Same thing with syphilis. That antibody does not mean you have active infection. You look at the screen part, which is that titer. That tells you if you have active infection.
And I've noticed, well, not that I've never had this happen to me, but if you start to see dots on your hands and feet, like black dots, you probably have gotten secondary syphilis.
Yep, that's very classic. That's the secondary stage of syphilis. If you see dots on your hands, palms, and your soles, very few things give you that. That is time to go to a provider as soon as possible and say, I need you to look at this.
And then what's going to happen after you get those shots, when those spirochetes start to die, you may start to shake and chatter. That's just part of it. When it's syphilis sometimes. Yeah,
when you shake and chatter after the shot.
Yeah.
So that has a classic reaction. And I always tell patients to see me is if you come in and you have a shot in your palms and your soles, you get a shot. I always tell people, anticipate this evening, you're going to get fevers, chills, shaking all over the place, very high fever. That's normal. It's actually has a name to it. It's called the Jarisch-Herxheimer reaction. It's common in secondary syphilis. You didn't think I knew?
Say that again. Who is he?
It's called the Jarisch-Herxheimer reaction. Yep, it really does happen. It's funny that you said that. It absolutely does happen.
Oh yeah, it certainly does, and it's
Yeah.
like ooh, it's interesting.
Yep. If you want me to spell it, I could actually put it in the chat. Hold on.
Sure.
Yep. You should ask your provider this. So if you should say, do you think I'll have the Jerish Herxheimer reaction? I think they'll fall right in the floor if you say that to them. So yeah, that's very secondary stuff. It is. They're going to be like, who told you all this? But yeah, it's very common, and you should be warned ahead of time. A lot of people think something's wrong because a lot of times you've gotten a big bicillin or a penicillin shot, and then you wind up with these shaking chills, and it scares the crap out of people. Just know that that's a normal reaction, because what happens is these spirochetes here get broken up and they cause an immune reaction in your body. You have all types of things happen, which we just described.
And could you just expound on there's a big outbreak of syphilis in this city.
Yes.
People should be aware of. So if you frequent the baths or the bookstores or sex clubs or share sex toys, just be aware that, about syphilis.
There is a huge outbreak, and a huge epidemic, I should say, of syphilis in the city. And one group that's really impacted are cisgender females. So, I see a ton of these in the OBGYN department, and very, very sick. They're very, very, very sick. And a lot of times, some of them have no symptoms and some of them have lots of symptoms. So it is really important. And again, I cannot emphasize to you enough. I go back, I'm actually going to go all the way back here for a second, because usually what I put in my first, really the take home point, it's not enough for your provider to say to you, your labs are fine. You want to hear, my kidney function is normal, you don't have diabetes, what STIs did you check before? Do I even need STI testing? I mean, that should be asked to you. Once a year I screen everybody for everything, but I actually ask the question, since you were last here, who put what, where, how, when, what did you put, where, when, how? You have to ask those questions, and they're uncomfortable. Just do it. Just do it, and you'll be like me. It becomes second nature to ask. But if I don't ask someone, do you put your penis on someone's, do you put your mouth on someone's penis? Do you put your mouth in someone's vagina, rectum? I'm not going to know any of that stuff. And then I'm not going to know where to screen you. And that's the most important part. It's not about, and again, there's, I practice in a setting where the people I take care of know I only am asking this question, never to judge them, but it's to make sure they get the appropriate screening. I also am totally aware that providers place their judgments, and people don't want to, and I don't blame them. They don't want to disclose that stuff. So I will say to you, because I think it's so important, if you are someone who is uncomfortable discussing sex with your provider, it's a problem, then you need to seek other measures. So going to Health Center 1 or going other places where you can feel free to say, I've had 3 sexual partners in the last month, and not feel like you're going to be judged. And that's what you need to do, because you not telling your provider you're not getting the appropriate screenings, and all these things have consequences. I didn't even bother talking about if you have maybe untreated Hep C, Hep B, if you have syphilis, you can go blind. I mean, there's so many things. So not getting the screenings is not the answer. Find somewhere where you can go, where you feel like you can have a conversation and not feel like you are being judged.
And even interwarts can lead to, you need to get a visual on your rectum, because interwarts can lead to cancer and other issues. And you don't want that little issue going on.
Yeah, no, I will say that, I know a lot of providers my patients know, if anyone's on here I take care of, I do not send you to the bathroom. I mean, I will look at least, most of the times I will do the swabs myself. You know, sometimes patient, I don't want you to do it. It's very rare, but I need to look, right? Because I'm the one that can look and see, oh my God, it's very hard to take a look at your backside. It's very hard, right? Unless you have a mirror, you could try to do whatever you want, but you want someone to take a look there, right? It's not just about doing your probe. Are there warts in there? Are there hemorrhoids? Are there fissures? Is there a malignancy? You should have what's called a digital rectal exam, where someone puts a finger in your rectum, because most of the times if you have a mass there, you can feel it with your finger alone.
That's exactly how I was diagnosed with anal cancer recently.
There you go. And we didn't plan this beforehand. So
Right.
really important things that go on in this room that you see here, this fictitious room. And if these things don't go on, then you need to find other places to have them, because ignoring them is not going to make them go away. You don't want to have problems later on down the line that could be preventable.
So you do an extensive sexual health history with your clients, with your patients.
It's gotten to the point, and I laugh because I'll say after we talk, okay, let's go over to the the exam table, and I turn around, their pants are down. I'm like, wait a minute. I want to examine your mouth, your lymph nodes, your heart, but everyone just knows they're going to get STI testing when they come to see me. But I'm like, let me do your heart and lungs first, please. You know, they know it's important. And you know what? I do find a lot of STIs, and that's important. And I want those things treated for your own health. And then you also run the risk because a lot of them are asymptomatic. I don't want you giving it to someone else. So yeah, there's a lot of reasons there. And with that, I'm going to stop. I'm going to actually end my slides just so I can see people if anybody wants.
So so now we're going to open this up to all panelists that are here, not just panelists, but all the participants. Feel free to ask any question that you want about any of the tests. And I was going to, because this is kind of like an aging topic too, as you age, there are about like 7 different diseases associated or comorbidities associated with aging. Would you say like high cholesterol, which we covered, high blood pressure, heart attacks, diabetes, kidney disease, depression, anxiety, bone loss, cancer? So would you, there's a lot of comorbidities. As we age, you need to start to be aware of some of these things as well, just to get a handle on it.
Absolutely. Yeah, so, we talk because HIV accelerates some of these things, so it's very important. I can't emphasize enough how important it is to do a lot of these screenings. And again, walking into a provider's office, having a lab slip handed to you, go to the lab, and you never hear, or you hear everything's fine, that's not enough. You need to know what is fine, right? Or if you have someone, and it doesn't have to be the provider. I mean, if you have contact with someone in the clinic who could go through this stuff with you, I think that's important. Or maybe it's not there. Maybe it's your next visit. You should go in with a list and say, could you tell me how my sugar was? Am I pre-diabetic? Can you tell me this? Can you tell me, is my liver function okay? I mean, you'll see providers' head will shake like, whoa, wow. And then, it's because we as providers, I'm one, I see a lot of patients, I get a lot of labs on a lot of people. And, I have to figure out a way to organize myself that I know, like today, I know when I'm done here, I've been waiting for someone to get undetectable. It came in yesterday. I put it in a box. As soon as I'm done here, I'm going to call him because he wants to go on the long-acting injectable. He's going to be happy. I have that. And then I have someone else I have to call because their viral load was high and they were supposed to come back in Monday and she didn't come. I'm going to call her. And someone else's, liver tests are now down. So I have these things that I need to call them about. So it's really important to have these conversations. And you shouldn't be afraid to have these conversations with your provider.
No, because either you pay now or you pay later. And I'd rather prevent instead of having to go through, other major complications that are not fun.
I think the 2 ones that really stand out to me, well, one, the STI, I think I beat that to death. But the one is, pre-diabetic. You know, a lot of times people don't always tell you you're pre-diabetic. You want to know that, because pre-diabetes is where you can reverse it. Get out, the weather's going to be hot, but get out, walk, do some things, get that body metabolism going. I know I'm preaching to the choir. I need to be preaching to myself. You know, maybe cut down 1 Pepsi a day from the 8 that you normally drink. Things you can do, right? You don't want to wait till someone says, oh, you're diabetic. Now I'm going to give you metformin. Now I'm going to do this. Now I'm going to do this. Now I'm going to do this. Try to reverse it early on. And that's really key.
So, okay, because I'll just want to ask one quick question for you. So is there anything that you can do? Is there another test besides a colonoscopy for people?
Yeah, so if you want to do colorectal cancer screening, there are a couple different tests you can do. The big one is obviously have a colonoscopy. And again, this is starting early on. You know, this is starting in your 40s. But if you have a parent that had cancer, you know, you want to get that done earlier. And that may mean in your 30s. You know, again, this is a conversation you want to have if you have a first degree relative. So if you have none of those, you're just what we consider average risk. What you could do if you don't want to, you remember colonoscopy, you have to schedule the appointment. You have to not eat the night before. You have to do a prep, which everyone dreads. You can also do something called Cologuard, which is where they deliver something to your door. You put stool in the package and then send it in to the place that sent you this, and they look for DNA in there. There are some false positives with that, but you can do that and then get it repeated every 3 years. But just know that if it does come up positive, you need to get a colonoscopy for that. That's a good question.
Let's see. Does anyone else, any of the participants, have any questions for Bill? It's a great chance to have some of those questions or help you out with that. You can put it in the chat, you can put it in the Q&A. And I know the big question that most people always have is, will your slides be available?
Yes, for sure.
Yes.
Yep, I can send them to whoever. I don't know, Kat, send them to, who would I send them to?
Yeah, just send them over to Dr. Reader.
Okay.
If anyone wanted to access those slides, we could send them on
Sure.
over. We are at time, so if there aren't any more questions or comments in the chat.
It went fast.
It did. This was an amazing presentation, and it was so involved, and I really liked that everyone participated. It was really amazing.
It was amazing. Yes, I just want to, real quick, I don't like to haul. I just want to thank everyone. Hopefully you got something out of this, and even more important is I want you to feel like you should go into your provider, and maybe not everything I said, but at least 1 or 2 things, and go in there and really feel empowered to have those discussions with your providers. It'll change the dialogue, and yeah, just I'll leave you with that. And thank you all so much. Enjoy your summer. And I hopefully can come back and do this all again.
I want to thank everyone who participated today. I want to thank Dr. Short. I want to thank David Griffin and Amy from the PEMCFAR who helped us do this the first time around. So hope to see you again. And thank you so much, Kat.
Yeah,
Thank
we
you
got
all.
a lot of thank yous in the chat box.
I know, it's so nice.
All the thank yous. So with that, I'd like to say thank you to our panelists for your thoughtful and insightful presentation. And thank you to all of our viewers for joining us today and all of our presentations throughout this month. It has been my pleasure moderating these presentations. A special thank you to this year's sponsors for AEM for making this virtual summit possible. And with that, I say a final thank you. Take care, be safe and well, and have a wonderful day, and see you all next year. Woo!
See you later.
And Dr. Short, I need to get your phone number, or you can send me an email because you had some questions before.
Accept my Facebook request, and then I'll give it to you.
Oh, okay. All right. All right,
I'm
no
gonna
problem.
get you there.
All right. Have fun, everybody. And enjoy the view.
Yeah,
Thank you.
exactly. Take time to enjoy the view. All right, thanks everyone.
Bye. Thank you.